morning. For those that have joined by Zoom, hi, I'm Jo Dean. We want to welcome you to the Primary Care Virtual Community. Start off by saying hello. Go to the chat room, the Zoom webinar chat. Press to all panelists and attendees and say hello. Hello, Cindy. Where are you coming from? Judy. Oh, I see. Judy, Leanne, Cindy, do me a favor. Go to the to who you're sending it to and change it from all panelists to all panelists and attendees so everybody can see you. Hello, Robert from the UK. Welcome. Hello and good morning, Leanne from the Ontario College of Family Physicians. Isabel, RN from Briar Academic Family Health Team. Good morning and welcome. Yinka, good morning. Who else is on the line? East Elgin Family Health Team, Cindy, welcome. Lori from Manitoulin Island. Laura from the Association of Family Health Teams. Dr. Richard Johnson, Pembroke Family Medicine Teaching Unit. Anne at Haldeman Family Health Team. Judy, Georgian Bay. Isn't it incredible to see people from all across Ontario joining us today? This is the beauty of a virtual community. Hopefully I don't miss anyone. Declan from Rowan Family Doc and Petawawa Family Health Team. Steph from Brockton Family Health Team. Carolyn, Executive Director from Plantignet, excuse my poor pronunciation, Family Health Team. And Dale from Kawartha. Welcome, welcome. Central Brampton Family Health Team, welcome. I'm Jodine Goldhar. I'm from the Change Foundation, and I have the great privilege to convene today's virtual community with all of our esteemed attendees and guests. Welcome. We will do some introductions soon, but let's keep the welcomes coming in. For who has joined us on the virtual community, please press to all panelists and attendees when you go into the chat room and introduce yourself and tell us where you're from. We have people coming from all over Ontario this morning. To Sandeep from the Ontario College of Family Health Team in Mississauga, Halton Lynn. Welcome, Sandeep. Diana, Village Family Health Team. Hello, Monique from the Star Family Health Team. Welcome, welcome. Darren, good morning. Darren Larson, nice to see you virtually. Sarah, Dr. Sarah Newberry is welcoming people online. Anna, welcome. Amy from the Ontario College Family Physicians in Shelburne. Good morning, Claudia from the Blue Water Primary Care Team. Nice to have everybody here. It's really exciting to see so many people join us from all across Ontario. That was our goal. Can we connect us all up, create a virtual community together that is about positive change? And it's so nice to see so many people joining us. Joanne from Burlington, welcome. Hi, Jennifer. I will have to duck out for the, no problem, Jennifer. I'm glad you could join now. There'll be many more to come too. And for everybody online, we are taping this session. Everything will be recorded. And if you miss any because you have to duck out, we will be able to share. Plus we will be able to share with others. So welcome. Who else is on the line? For those that have just joined, please go to the chat room, introduce yourself, tell us where you're coming from. Kathy Bujaya, so nice to see you. Welcome, welcome. It's our pleasure to do this. Dominic, hi. We have 70 participants online so far. That's incredible. Tamar, welcome. Tamar, where are you coming from? Maggie, wonderful to see you. For those of you that are participating, make sure that you press in the chat room, not just to all panelists, but to all panelists and attendees. That's the only way everybody can see the chat room. We, as a team, there's a few of us here who will summarize what's on the chat room to share out, but for you to see everything, you need to go to the chat And when it says to, due to all panelists and attendees. Hi, Alan. Good morning. Glad you've joined. Tamar, your Chief of Family Medicine and City Lead, welcome. Mary Jane, Aurora Newmarket Family Health Team, wonderful. We have 75 people online representing all different geographies in Ontario. It's incredible. You know, virtual platforms are a great way to connect us all up for positive conversations about health system change, and we're so excited that you're all online. I want to welcome Dr. Ruth Connolly, Chair from Somerville Family Health Team, Vanessa from the Ontario Association of Social Workers. Hello, hello. Morning, everyone. Beth McKinnon from AFTO. Good morning, Beth. For those that are just coming online, please go to the chat room and say hello to us. Tell us who you are and where you're coming from. When you go into the chat line, please make sure in the to section you press to all panelists and attendees. Good morning, everyone from Guelph. David, good. Good morning, Marge from AFTO, board member. Welcome, welcome. As most of you can see, we are now at 80 participants. We have over 150 signed up for today, and you are all logging on in amazing order. Lisa from Health Quality Ontario, welcome. Lee, family physician from Orleans, welcome, welcome, welcome. For those of you who don't know and weren't online yet, I'm Jodine Goldhar from the Change Foundation. The Change Foundation has been asked to convene this virtual community on behalf of all of you, and I am honored to be the facilitator today. Please continue to say hello. Sue, do me a favor, Tobin from Ingersoll, nurse practitioner-led clinic, welcome. For those in the chat room, some of you are, when you put in your hello, you're just putting it to all panelists, which only goes to us that you can see on the screen. Instead, could you go to all panelists and attendees? That way, all of us can see the chat. So Andrew Wong, could you please do the same from Health Quality Ontario? Right now, your communication is only going to the panelists and not everybody online. Laura from Association of Family Health Teams, perfect. Andrew, good, from Health Quality Ontario. You've done it to all attendees. That's fabulous. Hi, Tamar, thank you. Wonderful, wonderful. So, in a moment, we will open up this screen for you to see all of our panelists today, but you right now only see me, Jodine Goldhar from the Change Foundation. Carolyn, welcome, welcome, and thank you for chatting in so that everybody can see your responses. Tamar Packer, Chief Family Medicine, HHS and St. Joe's Hamilton Health System. Hello, Cynthia from St. Joe's Healthcare London. Welcome, welcome. So I want to welcome you. Paul, Newmarket, South Lake Academic Family Health Team, wonderful. So we have approximately 85 people on so far, 150 signed up for this morning. Our goal was to use Zoom as a way to connect us up all over the province, people from different geographies and in different roles in primary care who have a passion and interest in supporting and highlighting the incredible work of primary care in Ontario. And we welcome you to this virtual community. It is our second, and we will share more around the goals and objectives and really look to you for what would make this community incredible. Lisa, you're saying it's so nice to see so many familiar names and old faces online. I bet many people agree with that sentiment. Welcome, welcome. So right now on your screen, let me share with you a little bit of how this will work. Right now on your screen, I believe you see me. That will switch in a moment. So the person who talks is whose screen you will see. But what is very important to us and what will ensure the success of our community online is that the chat, I'm sorry, I'm pausing because I'm looking at Darren Larson's comments on chat, which is there's clearly some humor between some friends happening on the online community, and that's exactly how this should happen. Please feel free to use this chat any way that you see fit for us to realize our potential as a community. And Darren, the humor is perfect, but of course it distracted me. So the virtual community is meant to connect up anyone in Ontario who is part of primary care or interested in primary care or believes in the potential of primary care, for us to come together in this new way to connect up and have meaningful conversations. The Change Foundation has been asked to convene this because we are a neutral party in Ontario, with no affiliations except to help improve Ontario's health system and support positive health system change. And I feel lucky and honored to be asked to facilitate and convene this group on behalf of all of you. Let me tell you who is joining us today. First, behind the scenes is Kareem Suleman. Kareem is part of the Change Foundation team, and as you can imagine, to develop a virtual community, it takes a few of us behind the scenes, and Kareem has helped organize the logistics and the planning, and he will be here to have our back in case anything goes awry, to help make sure that we all run smoothly. Then there is Yinka McCauley. Yinka is the backbone for this work. She connects us all up and helps ensure that the goals and vision for this work comes to life. And you will meet Yinka in this session because Yinka is monitoring the chat room, and Yinka will share a lot of the themes and feedback that are coming forth so that she can pull it together if the chat's going through very quickly and we all don't have a chance to see some of the themes coming up. Then many of you know Dr. Sarah Newberry and Dr. Rob Ennis well, and I'll introduce more of them later, but they are part of the core planning and leadership for this virtual primary care community. And then we'll do a formal introduction after, but Dr. Robert Varnam, who many of you have met. He was with us in our first virtual community, and then the March 25th day that the Ontario College of Family Physicians hosted, Rob was zoomed in from the UK. And the reason why Robert is with us again is because the journey of primary care in the national health system is very reminiscent from the journey that we are on in Ontario, and a lot of you have said that his experience has been very helpful, and so we are building on those past discussions, and Rob is joining us today. The goal is that this is an interactive session. This is for you, so please do not hesitate to use the chat box, and we will have very specific times for us to discuss a lot of key questions and a lot of what the team will be facilitating and talking about. I do have to go through some housekeeping pieces. So again, please use the chat, and I see that many of you are using it, and it's wonderful. A reminder in the chat to press when you're responding, all panelists and attendees, so all of us can see. Please know that this session is recorded, so that after we can share it with you if there's anything you'd like to review again, but you are welcome to share far and wide if you think useful to anyone who may be interested in joining us in the future, or who would get value out of being part of the community or hearing the discussion from today. We are monitoring the chat box, and we will be able to share back what we are seeing and hearing. We have great news. This is real-time news. As of midnight last night, we were approved for credits, the Main Pro credits. And now we are working on the full series receiving Main Pro credits. So as you know, there are some requirements that we have to include in the logistics and housekeeping. I'm just going to walk through some of those, the disclosures. So Dr. Robert Varnam, Dr. Sarah Newberry, myself, and Dr. Rob Ennis, and Dr. Robert Varnam, all the disclosures have been made. I have a special ask of all of you. We want this community to continue beyond what happens during these virtual sessions. So if you are willing, will you please share with us your Twitter handles? Mine is at Jodim Goltar, and Kareem is putting it into the chat now, along with our whole team. Can everyone take turns and put your, thank you, Robert. Thank you, Dominic, Alan. Keep it coming. Sarah, share us your Twitter handles. And let's make commitments. Hi, Javid, nice to see you. For all of us to be connected via Twitter. We know that we can move at the pace of change at a much more rapid speed when we use virtual means. I was just at a session at the IHI, the Health Improvement Quality session in Glasgow 2 weeks ago. And one of the #1 areas of focus to accelerate large-scale health system change was through virtual means. And the key around virtualization is that it's relational. It's about our relationship with one another and not the technology itself. So you are all coming in fast and furious with your Twitter handles. That's incredible. The commitment from our team is to make sure we share them out far and wide so we can communicate with each other. We are using a hashtag for the virtual primary care community. Hashtag primary care leads. You see it on the screen. Kareem has just put it on the chat box. And we've chosen that for a particular reason. And before I go to Sarah and Rob to share, the rationale for why primary care leads as a hashtag appealed to them, in the Twitter box, in the chat box, can you tell me what it means to you? What are your thoughts and reactions to using hashtag primary care leads as a way for us to communicate? Hashtag primary care leads, what does it mean to you? Okay, I'm going to turn to Dr. Rob Annis and Dr. Sarah Newberry to share, but let me introduce Rob and Sarah. Oh, okay, some are coming in. Javid, inspired setting of direction and identifies who's leading it. Excellent. For Leanne, primary care is the foundation. It represents the fact that, oh wow, they're coming in fast. Cindy, that primary care represents groups that lead change, moving primary care forward into the future. Good. Primary care at the forefront of healthcare. Excellent. Is there anyone who has any concerns with the hashtag primary care leads? This is a safe space. We want the hashtag to represent what matters to you. None. Primary care helping shape Ontario health teams, cradle to grave. Great. So now let me thank you, everyone, and thank you for being so interactive. It's exciting. There's energy in our virtual universe, and you can see that everybody is engaged and participating. John, I don't think our system yet values the role of primary care leading change in the system. Demonopolizing specialist care to the primary care home. Okay, well, thank you for sharing your perspectives. Our goal is for this virtual community to be a massive contributor to positive change in Ontario's healthcare system. And anything we can do to make this a positive experience for all of you, but also a positive contribution to health system improvement, it takes all of us to do that. Now I'd like to introduce two of our primary care colleagues. Dr. Rob Innes, who practices in Listowel, Ontario, in association with North Perth Family Health Team, and happens to sit on the Provincial Government Primary Care Working Group. And Dr. Sarah Newberry, Rural Family Physician in Marathon, Ontario, with the Marathon Family Health Team. Steering Committee Chair for the Ontario College of Family Physicians Leadership and Primary Care Mentoring Initiative. Rob and Sarah, what does the hashtag primary care lead mean to you?
So maybe I'll go first, Rob, if that's okay. And I'll just say that so many of the comments that have come up on the screen really resonate for me. Most importantly, I think the value of primary care at the foundation of this system. But I also see it as a call or an invitation to us in primary care to step into that space, to take ownership of primary care and the opportunity that we have to shape change. Rob?
Yeah, thanks very much, Sarah, and I hope everyone can hear me. And I'm appreciating the humor on the screen so far this morning. It is good to see many of my old friends there, but also many of my young friends are on the chat as well. So welcome everybody. I love the double entendre of the primary care leads. So the verb-wise, we know that internationally systems that have primary care as foundational are the ones that serve patients best. And also as a verb, we have many great people leading. Now I'm very proud of the leadership in Ontario. But there is a need to move that from central, regional, upper leadership to local leadership. And so we have leads both locally and sort of higher, big L leadership. So it has a number of different ways of looking at the phrase. So I think it's a really one that fits for us well.
Wonderful. Thank you. Is it okay? I'm switched? Okay. There's some great discussion online about the Ontario focus is missing from the hashtag, and perhaps we call it Primary Care Lead ON. Thoughts and reactions. We are happy to make that change. It's a good idea. But what do people think? Just a reminder, if you're coming on the chat, Alan Schur, Darren, or Leads on Ontario. Tamar likes it. Great idea. Okay, thank you, Cindy. Marge, yes. To each of you, please come on the chat. I agree to add, great. Or put on at the start. Sounds right. Okay, great. Thanks for suggesting this, Darren. Great idea. Lots of support for this. Ooh. Declan, primary care leads on health. Okay. Maggie, I like it. Keep it in line with other Ontario initiatives. It's true. True. Ontario primary care leads. Okay, so we will have a new hashtag. Any Rob, Sarah, of all the ones that you're seeing?
I like on hashtag ON, primary care leads. I think that works really well. Thanks for those terrific suggestions.
Okay, we have a new hashtag and it is launched. Hashtag ON, primary care leads. Our first collaborative piece of work together. Oh, Javed, I see what you're saying. You're saying add on health to broaden the audience. All right. Well, I think we're going to land with on primary care, action-based leads. All right, well, why don't we do this? Why don't we take the feedback, like the on at the end. Okay, so we all agree that Ontario, we want to highlight Ontario. It's just a matter of where and how. So I think it's fair to say, because the conversation is going on, we will decide towards the end of this and perhaps do a vote. We're going to try and plan for a vote at the end of this. There's a way to do a voting mechanism, and we're going to try and build it in towards the end of this if we can. All right, everybody. I now would like to turn it to Dr. Sarah Newberry to talk about where the start of the primary care virtual community came from.
Great, thanks so much, Jodine. I'm hoping everyone can hear me. I'll just look for a nod that sound quality is okay. Great. So Jodine has already touched really beautifully on where this began in the fall, which was some thinking that the Change Foundation was doing about large-scale change and transformative change in healthcare. And the OCFP and AFTO and the Change Foundation really saw an opportunity to come together to think about how that transformative change could impact primary care in Ontario. So we held our first webinar in November of last year, and there were 225 participants. Helen Bevan joined that, as did Dr. Varnam. And it was a really terrific, I think, opportunity to begin a conversation with all of you and so many of you who, to Rob's point, are leading change in your own practice context, in your community, and in your region. So in November, we used the same chat function that we're using today, and we heard several things from you. We heard that you were cautiously optimistic overall about primary care in Ontario. We heard that there were several things that you feel really proud of in Ontario, and a couple of those things were the emergence and the embracing of team-based primary care. We heard a lot about the value of QI and data and measurement and a focus on continuous improvement in primary care. We heard about the value that you see in family physicians and the commitment that family physicians make to improving the health of their population. Those things really mattered to you, and you highlighted those in the conversation that we had in November. So today is the first of 4 webinars, and part of what we're going to do is re-engage you in some of those questions. We're going to learn more from Dr. Varnam today, and we're going to circle back to some of the questions that you asked towards the end of the November webinar and engage Dr. Varnam in a bit more conversation about some of the things that you had some specific questions about. So we'll do that as his piece of the presentation today unfolds. So with that, I want to say welcome back to all of you who are joining us again for this first of the 4 series that we're embarking on now. Welcome to all those of you who are new to this community, and I really hope that we can continue to see the conversation move forward both today and through the hashtag that we land on in the social media space. Thanks so much, Jodine.
Thank you, Sarah. So we are now going to do a poll. And this is a poll question that we did in our first session. It's a new one. Oh, sorry. Okay. We're going to launch a poll, and we're asking you to please respond. The question is, as a way to start, how confident are you in the opportunity for primary care to lead on Ontario health teams to improve care and reduce silos? What is your confidence? And the reason we're asking this question, this came from primary care, not from the Change Foundation, because I think the idea of this virtual community serving as a source for positive health and social change and improvement in Ontario's healthcare system is, the goal is to understand how confident are you? And how can this community serve to increase confidence and to build on the opportunity for positive contribution and change? We are ending the poll in 3 seconds. So please, do you see people responding to the poll? Great. Sorry, I'm talking to the whole team in our office. Just want to make sure, and the poll is closing. Okay, so let's see our results. Okay, so interesting. We have a lot of people who are confident but need more time, and there's a range, some from total confidence to confidence but we need more time, some on the fence, and some are not confident or not as confident as you can be. It's interesting. I'm not confident at all. Nobody said that, and we now have over 120 people on this virtual community. So it's great to see that we do have a significant level of confidence, and we do have an opportunity through this virtual community, but in all the work and the partnerships you're doing in Ontario, to move positive health system change forward. I'm going to the chat room for a second because I'd like to see Alan, Dr. Groh, I would like to speak with the 14%. What they know that I don't, which is total confidence. It's going to be tough, Darren, work to organize against with some dominant groups like hospitals. I think that we can be vision leaders and bring direction, but lack the financial and administrative support to lead. That's Declan. Integrated care can't work without primary care. Well, that's for sure. It can't work with all parts of the health system. I agree with Declan 100%, Alan. Okay, Tell me what else you're thinking and reacting to. Does the poll surprise you? Any surprises? There is evidence that primary care and ACOs are successful. Not really surprised. Integrated care isn't integrated unless it's together. I think Rob's comment is a rallying call. Was it Sudbury OHT yesterday? Oh, they're going so fast. Okay. The confidence, we are working on an application to Markham. There's a ton of uncertainty. See North American Observatory work, yeah, from the Institute for Health Policy Management and Evaluation. It's groups like this that will support primary care leadership. That's Dale. Patients at the center and leave behind who's at the head of the table. Well, you know, Tamara, I love that. That's part of the Change Foundation's motto. Not really surprised, but more time will be needed. Okay, great. Just on a quick reaction, as part of this virtual community, which our whole goal is around positive contribution to Ontario's health system, how can this virtual community be supportive and helpful to what you're talking about? Share your thoughts and perspectives on the chat. Is this a good time for me to go to you for a summary? Or no, not for the summary. Yeah, no, it's okay. We'll do it the next one. Great point, Sue. The value of primary care has to start in the academic institutions and in the view of clinicians in med school and tertiary hospitals. Thank you, Ruth. Leanne, primary care lead, if there are resources to support this, voluntary participation should not mean volunteering. With such tight timelines, applications due May 15th, tough to engage primary care who book patients weeks in advance, right? So how do you meaningfully engage right now? Must also remember that the Ontario health teams are dominant in thinking right now, but this group extends beyond. That's Darren. Primary care needs to truly unify collectively as one powerful voice. Yes, Leanne, especially for small primary care teams. Yes, Sandeep. Great. Thank you, everybody. The applications for OHTs are rolling, not just the call. Small primary care groups, FFSs, don't see how they can resource leadership in Ontario health teams. Okay. That's great. We want this to be a place where we can have these discussions and also use the community to problem solve together and come together as one community. Sometimes good to be leading edge, not bleeding edge. My primary care includes an Indigenous lens as a foundation. We have to remember this in our planning. Yes, we do. Lee, my experienced primary care leaders is they know how to collaborate well with the system leadership because care for their patients requires collaboration. I'm sure I know everyone online appreciates what you just said, Lee, and know it's true. The limiting factor, not having a central body through which funding and accountabilities flow, lack of integrated information. Thank you, everybody. This is the chat and our opportunity to have a two-way discussion right now. Oh, Sarah, Darren, that's not a really helpful point. We can do a lot for primary care and for communities, whether primary care settings are part of OHT or not. Yeah. So this is, this is the thing about positive health and social contribution is also having the discussions where we can work through different perspectives and come together around a common goal. And I want to thank both Sarah and Darren for showing that that's possible as part of our community. Those are important discussions. I would now like to turn to, and what we are going to do is we are going to summarize this chat box so that as it's moving through so quickly and we're having many back and forth discussions, we will take the responsibility of summarizing everything so that it gets played back to you. I'd like to go, are the slides moving? Can we go to, please to the next question? And the question is, what are your priorities for realizing more of the potential of primary care within a joined up system to be more integrated? What would you say is most important to you and the priorities that we should be looking at? Yinka is going to be monitoring the chat line and sharing. I will show some of what's coming up so everybody can see and hear, and then Yinka will summarize. Okay, a single EMR from Ruth to link primary care with hospitals as a priority. One EMR. Access to mental health services, reduction in ALC beds. Many are agreeing with the EMR. Trust. I'm sure you've heard this before, but change only happens at the speed of trust. Building trust and relationships locally before building out the OHTs. Single EMR. Some things make sense to do locally while others don't. One EMR. Need to stop two-tier primary care. Primary care moves through the system seamlessly without even realizing it might be in different organizations. Integration with specialists. Funding model that commits more % to primary care. Rebuilding our role in transition. Strategic planning committees with hospital and primary care. What else is coming to mind? To be more joined up, to work more as a part of a system of care, what should be our focus? Improve communication with the hospital regarding your patients and clients, support for data, joining the QIPs. Dedicated time for primary care leaders to lead speaks to the point of not leading from the side of your desk. This is where hospitals have an advantage. If funding is not prioritized to primary care, then real change cannot happen or cannot happen easily. Small provincial organizations like Alzheimer's Society are concerned about how they will relate. Thank you, Stephen. Deakin is right. Need funding, especially for leadership roles in primary care. More equitable access to teams. Single EMR. Darren is sharing resources, and thank you, Darren, for taking the leadership. So if anyone has links to resources that you want to share with the community, David, hi David. David also shared, I believe, a Longwoods article, and Darren Larson shared a link around EMRs, electronic medical records. Ruth, hospitalists have appreciation for the value of family docs to give effective and cost-effective care for patients. Sarah, your point is key. Building relationships is really important. Okay, I'm going to turn it to Yinka, who's going to share a summary of what she's seeing in the chat room. Yinka, over to you.
Okay, great. So in terms of the chat room, we're seeing a lot of responses related to EMR, and sorry about the echo. We're just navigating some technical difficulties. Also the importance of trust and relationships, looking at how we can have courage in doing this work, care coordination, integration with specialists, working on improving our communication amongst each other, and supporting leadership within primary care.
Thank you, Yinka. Is there anything that missed for anyone online? Anything that Yinka and I missed that's important for us before I turn to Rob and Sarah to share a quick reflection? David Kaplan is saying he did some shameless self-promotion by sharing the Longwoods article, but the whole community is saying, we're so glad you shared it because it's so useful and it's a great article. So don't worry about shameless self-promotion. Everybody online are leaders and are contributing to positive contribution of primary care. So please do share the work you've done, what you're proud of, any resources that this community could benefit from. Collaboration with Indigenous partners. That was not part of the summary, and we will make sure we put it in. Thank you, Laureen. I hope I pronounced your name right. Okay, great. Oh, elephant in the room. Cynthia says, salaried providers have more flexibility to be involved. Is this true? We need to pay primary care providers to lead. Can't be done on the side of our desks. Yes. You know, it's so interesting. We're bringing up the focus of trust and relationships. Well, if change only happens at the speed of trust, then the time, energy, and effort it takes to build trust is the job. And That you cannot do from the side of your desk. Liz is right, time needs to be valued. Okay, thank you so much. So now, Rob and Sarah, do you want any quick reflections, and then I turn it to you to introduce Dr. Robert Varnam?
Sure. Go ahead,
Sarah.
Rob.
Oh,
I'll go first.
sorry. If the two of you could do a quick response, and then we have one more question before we turn it to Robert.
Great.
Go
Very
ahead,
quickly,
Rob.
I'll go. I think in terms of creating a joined-up system, I'd really love to see the vision of the patient-centered medical home take hold, and in particular, making care comfortable for patients as they navigate the rest of the system could be a role for that home. Sarah.
Yeah, thanks so much, Rob. It's really interesting. My reflection is really about process. And I think this kind of conversation where people are connecting and recognizing, I think, some of the things that they value in the comments of other people, building those relationships, I think that's really fundamental to creating a joined up system in primary care, and then ideally from primary care to the rest of the system. It's terrific to watch the process of this today unfold. Thanks, Jodine.
Thank you both. Thank you both. And before I turn to Rob to introduce Dr. Robert Varnam, we have one more question for you. And I'm not ignoring what's in the chat box. I'll just close with Dr. Alan Grill, suggesting that we read the 2019 PMH document from CFPC as a vision for integrated care. Alan, are you able to put the link on the chat room? If you are, that would be great, so everybody could have direct access. Okay, I'm going to turn this to the future. Given what you're talking about, the priorities for a integrated joined up system, what would make you proud in 3 years? What would you like to see in 3 years in primary care? What's on your mind? A compelling way of communicating the value and proposition of connected up care to primary care. Thank you, David. It would be wonderful to see primary care has the same respect and power that the OHA currently has, Ontario Hospital Association. New grads who are actually interested in starting a full service practice would make you proud. That patients have access to their medical records. Comprehensive team-based primary care was the actual foundation of our healthcare system. And all patients have a primary care provider. So when the question is, in 3 years, what would you like to see and what would make you proud? Stronger partnerships and collaborations with all valuable community and social services. Transitions are seamless. Again, I'm going to be turning to Yinka for a higher level summary. I'm just looking at incoming responses. You want to see a system that's designed specifically for the needs of 2020 patients? Alan, thank you for sending the link. Primary care is valued as a foundation of the healthcare system. We're able to say yes to take on patients being discharged to no family doc. Transitions to patients and families. Being able to measure what we are starting and be able to measure the improvement with integration. We are not asking how to make the healthcare system work, but how to make it work better. That would make us all proud. Less physician stress and burnout, yes. And I know Dr. Robert Varnam will be talking about that. Team-based primary care with equitable access. I'd like to see inequalities in resources decreased, yes. All teams to have allied health. Patients are able to get access to care. Keep it coming in, because if you're speaking, I know you are, from the heart and what's most important to you about what would make you proud and what you want to see in primary care in 3 years, then that's how our positive contribution happens. It's building on what's most important to us and what we believe in, so together primary care can move in shared purpose. Home care integrated into primary care. Primary care practices more joined up so patients who move don't fall in between. A dark hole. It's great. Okay, Yinka, are you ready if I turn it to you for a summary, and then I'll be, quadruple aim. And then I'll be looking to you to see, did we get the themes right and what's missing? Sorry. Okay.
In terms of themes, we have being able to communicate the value of primary care, seamless transitions, being able to have equitable access to team-based care, also new grads wanting to practice in primary care and starting a full service, and being able to measure our improvement along the way.
Hi, how did Yinka do? Is anything missing? Okay, it's important for us that you share your response and reaction. Okay, all providers and patients can communicate securely through multiple channels. 30% of healthcare budget to family practice and community practice. Okay, we'll make sure to, and continuous co-development processes. We're going to make sure to add this, but we see it as our job to capture your collective feedback so that you can use this as part of the community for ways that we can move in shared purpose. So thank you. Before Rob introduces Dr. Robert Varnam, just a quick poll online. How many people had the opportunity to hear from, look at the chat, I hear from Dr. Robert Varnam either in November or March 25th at the Ontario College of Family Physicians? If you have, just put a thumb up or a wave in the chat box. Who's heard from him? Yes, Liz. Thumbs up, way up from Leanne. Just trying to get a sense of how many are new and how many, thanks Declan. Susan, he was excellent. Javid, good. We're getting a little deeper with Robert today, so you'll hear more than before. Great. Okay, so I think we have a mix of folks who have had the opportunity to meet Dr. Robert Varnam and others where Dr. Robert is new. And so the way we have structured today is for those that have heard him speak, because we are building a closer relationship with Dr. Robert Varnam to help coach and inform some of the conversations we have in Ontario. For those that have heard, you will hear some new information, and we're going into greater detail today based on your feedback from previously. But for those of you who have not heard, we are also going to review the journey of the NHS so that you won't be missing anything. This is both a way to start from the beginning and build from the conversations that we've had. So I'd like to, could you help me with my mic? Turn it to Rob to introduce Robert Varnam. Okay.
Great, thank you very much. Again, I'll assume you can hear me. It's my extreme pleasure to introduce Dr. Varnam again. I've had the privilege of doing this before. And I think when he was, as is mentioned, when he was involved in our last webinar, at the end of it, there was a sense, and it came up in the evaluations of people wanting more. And so we really had to have him back to dive into this a little bit deeper. So he is first and foremost a family physician in Manchester, inner city, and has a background in primary care research and local service improvement. He spent the last 10 years creating improvement programs for primary care and integrated care in the NHS, and has led the creation of new national policies to transform primary care and payment mechanisms. So we're very pleased to have you here, Robert. We'll turn it over to you, and I'm also told that he's okay with Brexit jokes, so you can put those into the chat box as well.
Thanks, Rob. Do you know, I think some things might be slightly beyond a joke. We'll see. Well, hello everyone, good morning. It's really great to be with you this morning. As Jodine said, recognizing the fact that some people may not know very much at all about what we've been up to in the last 5 years in the NHS with primary care, we're going to give a brief reminder of the journey we've been on. I'm going to pick up some much more specific aspects. A few people have asked questions about exactly what it is we have done at practice level. And then a lot of people ask questions about how we've managed the political relationships in the system so far. And also ask some questions about leadership aspects. How do I, as a primary care physician, kind of join a movement or even start a movement of change? So we're going to address those three things, really. I'm going to give a quick reminder of what it is that we've done, pointing, I think, to some of the things you might want to talk about, I hope. And then we're going to pause and have that conversation. And then in my second little section, we're going to talk about some of the political relationships and how we've handled those so far. And then in the third section, we'll look at some things we're learning in the NHS in England about leadership and power, which will hopefully be not just encouraging, but quite practical for you. I just love the ambitions that you've been expressing already in the chat room. We're going to be sending them back to you as a transcript, but I'd encourage you, if you've posted in there one of your ambitions for the future of primary care, I'd really encourage you to write it down as a statement for yourself. Because I think, as David Dane was saying, for us to have a compelling way of communicating the value proposition of primary care to our colleagues, to grow their confidence, is really, really powerful. And I believe that by the end of this morning, everyone will feel a bit more empowered and equipped to have a go at doing that yourself. I am therefore going to tell you a little bit more about what it is we've been doing in the NHS over the last few years. This is my faculty disclosure. I'm receiving no financial reward for this, and I have no conflicts of interest. So you may be well aware of the fact that the NHS, the National Health Service in England, have been talking about integrated care, both from a professional level, bottom up, and in a policy sense, top down, for a long, long time. There's been any number of policy tracts and think tank publications and pieces of research pointing to the potential benefit and encouraging everyone to get serious about integrated care. And about 10 years ago, as a primary care physician myself, but interested in the way we connect up with the rest of the system, I was part of one of those big national policy programs looking at best practice and what we need to do. And we'd reached some really depressing conclusions. We'd been talking about this for years. We had done an awful lot, and we'd achieved very little real progress. Lots of activity, very little positive, guaranteed and sustainable benefit for patients or for practices or communities. And one of the big reasons, time and again, was that primary care wasn't part of it. I love what Rob Annis said earlier. I believe too that integrated care without primary care isn't integrated, so it's not going to achieve the hoped for benefits of primary care. And so one of the things that we've had to do is go back to thinking about why it matters. We've been on a journey of about 8 years now, trying to reboot our approach to integrated care. Not start by talking about what to do or what the structures should be, or what the governance should be, or how it should be paid for, but actually starting about why it matters. And actually, we've made a real effort to talk about why it matters to patients, to the people that we serve. And this is a piece of work that I was involved in funding from the Alzheimer's Society. It's great someone's mentioned the Alzheimer's Society in Ontario already, where they worked with patients who are receiving complex care to ask them to describe what their care was like. And this hastily drawn diagram, nothing clever or special or beautiful about it, from an elderly couple called Malcolm and Barbara, who live in the south of England, has been a really key part for us of creating the purpose behind a big movement to rethink integrated care. We've called it the web of care. And they literally went back through the 7 years of quite complex medical problems that they'd experienced as a couple. And they drew all of the people who'd been involved over those 7 years in providing care for them. And as you look at that, I think if you work in primary care, we're all going to look at that and recognise it. Wherever you work, you see this huge plethora of different teams and professionals. And then And you can Google Alzheimer's Society Web of Care, and you'll see some videos, including from Malcolm and Barbara, talking about this web that they drew. And some of the experiences that they describe, you'll recognise too, of the complete disintegration, disjointedness of all of these teams and professionals. They have nothing but praise for these individuals, but the overall experience and effectiveness of the care they had, pretty poor. Time and again, the disjointedness of these people meant that actually care for Malcolm and Barbara was a bad experience. It involved a lot of duplication. It involved a lot of missed opportunities to improve outcomes for them. It raises some major patient safety risks. They talk about the waste of time, effort, and money that was created by the disintegration of the teams that were serving them. And for us, this has been incredibly helpful at starting afresh about asking, why would it be attractive for us to work in a more joined up way? And then the second thing we've done is actually to focus in on the bit that always gets missed out, which is primary care, and to ask about why primary care needs help to be part of that. And one of the things we've used to do that is to talk about the needs of these people with multiple morbidity. And we've kind of traveled the country speaking with policymakers and funders and other parts of the system, as well as our primary care colleagues, talking about this graph, which may well have seen very well yourself. It just describes the fact that as we get older, we have more chance of having multiple long-term morbidities. And so in the UK, at the age of 75, there's about a 1 in 3 chance that you will have 4 or more chronic conditions. And what's key about that is that these are the people who are the growing part of our population, just as in Canada, just as in Ontario. These are the people with the growing sets of needs. These are also the people who don't need more and more specialist hospital care. They need joined up, generalist, holistic, connected, coordinating care. They need what only we can provide. And when you talk about, therefore, meeting the needs of these people with integrated care, to miss out primary care is incredibly damaging to the patient, and it means you will always disappoint yourself. The third aspect of our narrative, and we've talked a lot about making the case, haven't we, on the call so far, so I'll just share some of our narrative, has been to start with some of the strengths of primary care and to ask whether we're delivering the potential. So this is our current list in this narrative of some of the key strengths of primary care. And we've been able to use this to connect with people's values and to recognise that the people who work in primary care see these things and say, yeah, that's why I'm proud to be a nurse working in primary care. That's why I'm proud to be a physician or a manager working in primary care. But it rapidly, in fact, usually automatically, leads on to people saying, but if I'm honest, I recognise that we are not delivering that full potential. And for us, there are some key reasons which I think resonate with a lot of the Ontario experience right now. The first is we are drowning in workload. It's not just a matter of morale, it's just that the numbers don't stack up. We can't keep going with this rising demand. The second is that although we have a holistic and a comprehensive perspective on our patients' needs, we're mostly set up to provide medical care, medical treatment. And that's not holistic enough. It's not proactive enough. It's not population focused enough to deliver the potential. The third thing for us as you is that most of us feel that we lack the kind of collaborative relationships with other teams, with other professionals, to be truly central to the patient's care. And lastly, we care about a population focus and dealing with the social determinants of health, not just treating people when they're sick. But we're too small and we're too isolated to have a really significant impact on the population or the rest of the system. You know, me as a single doc or us as a single team, can we really be sitting around the table with the hospital? It's very, very hard because we've been too small, too isolated. And so 5 years ago, we had reached enough of a commitment and almost a pressure, people saying something has to give, something has to change, that we launched a program of policy development and organisational development and leadership support to create integrated systems of care with primary care finally at their heart. I joined the NHS England, which is the national policy team, as a passionate primary care physician, but also as an improvement advisor, to be part of leading this policy. And our priorities were kind of multiple, and we made no apologies for saying they're multiple. Number one, we wanted to help primary care manage workload more sustainably. We needed to put more money in people and help productivity to improve on a day-to-day basis. We also wanted to promote more at-scale working in primary care to address some resilience challenges that we have for smaller practices. And we wanted to promote collaborative care regardless of some of the traditional questions about mergers. And we often talked about saying we wanted integrated care, not necessarily integrated organisations. And over the last 5 years, I'm not going to pretend that we've got it done yet. Anyone who knows anything about how we're at will know that we've got a long way to go still. But firstly, we've been able to see the acceleration of change in a growing number of communities around England, where groups of practices have been working differently, collaborating across primary care, and joining into an integrated system by collaborating with the rest of the system. There are some parts of the UK that are doing great work with the patient-centred medical home in partnership with hospitals and community trusts and mental health providers and people in the community doing voluntary work. It's really working in some parts. And right across the country, this is now normal. This is the new future we're working towards at a policy level, at a paying level, at a developmental level. It's sort of the new normal that we're all working towards. We're seeing some benefits, not just for patients. We're seeing some great examples, and really happy to talk more about these if you'd like to, on a more self-interested basis for practices ourselves, some benefits of working together, some benefits of increasing our scale without losing the personal flavour and atmosphere and culture in primary care. I think we have learnt some big policy lessons, and they're not necessarily very comfortable ones, but we're learning that if you've got big transformation ambitions across a big patch like Ontario, like England, our traditional response of creating new structures in a very top-down way just doesn't work. Or we just do panic response, and that just doesn't work. We've had to exercise some discipline in working differently. This time we've been trying to do many, many things simultaneously as leaders at a national level and as leaders at a local level. And again, if you want to talk more about any of these, we can return to this, but that's sort of our multiple simultaneous working that we've had to go through to achieve it. And lots of people have asked me to just say a little bit more in specific terms about one aspect of that. We've talked here about the practical examples that we've been sharing that actually help people to do things better. And so I'd like to share what they are. We've called them the 10 high impact actions to release time for care. And they are, in one sense, nothing more clever than a group of case examples from practices who have worked slightly differently to provide good access for their patients and found that it's possible, firstly, to free up physician time, which for us is an absolute must do. We cannot have our primary care physicians being part of integrated care or even finding they survive their careers unless we free up time. We've got to do something about the workload challenge. The second thing that's really interesting about the use of these 10 high impact actions is that all of them work better if you do them in collaboration with other primary care practices locally with you. Sharing ideas, sharing examples, sharing the burden of work, if you're doing service improvement, quality improvement, turns out to be quicker and more sustainable if you do it in collaboration. But the third thing about it is that although these have been really appealing to a huge majority of GP practices in our country, the uptake has been just insane over the last 2.5 years. Actually, taking steps on this has helped not just to free up time for being part of integrated ways of working, but it has helped us to reach outside the boundary of our own practice and to start connecting with a community, start connecting with other providers. And that has been really pivotal for us. It's not been enough for us to set a big policy ambition. It's not been enough for us to provide financial incentives for collaborating in integrated care. We've had to go right down to day-to-day family practice and ask, how can we help you practically to work differently? So we've shared these examples of how people have been doing this new kind of working, and case studies. You can see them on this website online. And we've provided improvement advisors and facilitators to use the QI skills to put it into practice. And we've created local action learning collaboratives using IHI's Breakthrough Collaboratives model in sort of town-sized areas to actually practically help groups of practices go through the process of selecting their change, implementing and embedding their change. And all of that has helped us to simultaneously, and there's been an awful lot of like twin track or triple, quadruple track working, to simultaneously release time and help people work in new ways in greater collaboration. And we've got a model to describe doing the right thing at the right scale, which is taking individual practices, bringing them together in what we call a primary care network. It's sort of our brand of the patient-centred primary care home at a neighbourhood level, to enable those to be part of place-based networks of care where it's much, much easier, far more feasible for other people to partner with us. Lots of people, it turns out, want to partner with primary care. They just find it really hard to meet with all 57 of us. But if we've got 57 of sort of represented by one network, it's a lot more feasible. And then we've said there are some aspects of planning for the future and big system investments where we need to be working at much bigger scale. So we're talking about integrated care systems, and we're helping every hospital network and mental health provider and our social care systems to be part of a single big system, but with nested networks of teams within them. And crucially for us, we have been quite encouraging people, and we're increasingly providing national funding to let people do this collaboratively, relationally, without having to merge. So this is about integrated working in relationships rather than integrating or merging the organisations. So that's a very quick sort of précis of what it is we've been doing and some key things. Really happy. I'm going to pause now and hand back to Sarah Newbury and Rob Annis, because I know we've got loads of questions already coming in, and in conversation over the last few days we've been coming up with some of our own questions as well.
So Robert, if I could, I'm going to circle back to a question from the November webinar. And I think you touched on the importance of physician time and creating capacity. And one of the questions that people posed in November was, what did you stop doing in order to create space for innovation? And I wonder if you could comment on that.
Robert, you're on mute.
Apologies.
We didn't hear you, so start from the beginning, please.
I will start from the beginning. So the biggest thing that we have done is use the 10 high impact actions to release time for care. So I'm just going to quickly just go back so we can see those all on the screen here for us. What we have traditionally wondered is whether the only way to help free up time might be you've got to just say no to patients. What we've actually done with the 10 high impact actions is to find new ways of meeting patients' needs that are less demanding on our most constrained resource, which is GPs, doctors. So if I go kind of very quickly to see if this highlighter works here. Oh, I think it does. Excellent. So I'm going to try this. So for example, at the point where the patient contacts the practice, we have traditionally, I think, picked up the phone and said, hello, it's the practice. When do you want to see the doctor? Now we are training up our reception teams with information about a whole directory of local services and the appropriate way of using them, to pick up the phone and say, hey there, who are you? How can we help you today? What's your issue? What's your need? How can we direct you to the right person? Secondly, we've been helping lots of people. We've been providing training and some funding to seed fund people trying out phone consultations, which often take more like 7 or 8 minutes per contact instead of a traditional more like 10 or 11 on average for us. We've been really growing very fast the use of online consultations. Some problems do not need to be seen face to face by me, particularly a follow-up for someone. I want to say, you know, try this new medication, try it for 3 or 4 weeks. If it's not working, let's go back to the original one. But if it is working, keep going. Just let me know. I don't need the patient to take time out of work to come down to see me. They can send me the message on the online system. So a lot of what we've done, things like that, is about doing access differently, doing the journey, the process. Some of it actually has been about diversifying the team within the primary care practice. For years, the majority of practices in our country have had doctors and nurses and nobody else. And increasingly, we have been seeing people employing physical therapists, mental health therapists, particularly for affective disorders, sort of mild and moderate anxiety and depression, employing emergency care practitioners, and a much wider, more diverse team. Because one of the interesting things for us is not just the volume of workload, but questions about appropriateness, or even frustrations about appropriateness from physicians saying, it's like patients think I'm here for everything, and I'm not. I'm a doctor. And so helping the practice to have a more diverse skill mix within the team has been really key for us, but also recognizing that there are lots of people outside the primary care practice who could be part of the solution. So working in more collaborative partnership with pharmacies and the voluntary sector and other people like that, doing something we call social prescribing, which is essentially to say, rather than increase the dose of your antidepressant medication, I think this is a problem of you being lonely and struggling with your life, and I can't help you with life, but can I connect you with someone who knows about all the things going on in the community around here? 19% of consultations with primary care in the UK are thought to be driven by primarily social rather than medical need. An awful lot of our mental health problems and others that are presented to us. So social prescribing has been a great way of doing that. And what's been really interesting for us, we published the 10 high impact actions 3 years ago. And we've been going around the country. I've lived on trains for the last 3 years, taking these round to people and the case examples and sharing the examples of them. What we're seeing is that these don't just help the primary care practice free up doctor time. They're actually better for the patient. This is actually about improving quality, improving access, improving the appropriateness of care for the patient. And practices are starting to be able to use the freed up time. Often it's about 10 or 15% of time can be freed up by implementing 2 or 3 of these. They're using that partly to make working life bearable for doctors again, but partly, and really importantly, so we can spend more time with the patients with the really complex needs who need, I need 20 minutes, I need 30 minutes with them. And we've just not been able to do that until now.
Thank you, Robert. And to everybody online, you've been so active on the chat, which really shows your engagement. And thank you. Thank you for helping us maximize a virtual community to have these discussions. A lot of you talked about Robert going into the 10 high impact actions in more detail. For those that participated before that came up, and I know Robert just did that. Before we move on to to the next part of the session, is there any more information about these 10 high impact actions that you'd like to know about? Please just ask the questions on the chat. Okay. Right now it's not coming up. So Robert, thank you for going into, is there one of these that has the greatest impact? And what does reduced DNA mean?
Really good question. In reverse, DNA is non-attendance. So a patient who books an appointment and doesn't use it, wasted time, wasted slot. Really good question about which is the biggest. I would say that it depends largely on your baseline. What we have found so far is that every one of these seems capable of releasing between 7 and 15% of physician consultation appointments. And in some cases where the baseline or the practice is really struggling, it can be way higher than that. So there are some inner city practices in London who have used active signposting, and they freed up 27% of their appointments within 3 months, which is just phenomenal. Most people feel that they've got a bit of a problem and they could maybe achieve some benefit. So far, we're finding that most practices and groups of practices are really surprised by how much the impact can be.
And Robert, one final question before we move to the other section was about quality improvement expertise. And the way Jennifer framed it, I hope I get this right. What are you measuring and how?
So we're using this to refer to the fact that if you want to get any of these changes into practice, it really helps if you understand change and leading change, and QI tools, model for improvement, process mapping, and PDSA cycles, for example, are really powerful ways of making a change much more quickly with less effort. But also, we found that if we simply train up staff in a practice to use these tools and just leave them to it without providing any other menu of options for them to do, they inherently go and find better ways of working that frees up everyone's time and improves care for the patient. So we put it in as one of the actions of its own right, because you see time and again people using their newfound skill and confidence at quality improvement.
Thank you, Robert.
As a means by itself to start releasing time.
That's great. You know, online, we're even being asked if we could do just a totally separate webinar on the 10 high impact actions. And so we are going to table that because that has come up at all 3 times we have had the opportunity to engage with you. So many people are saying, I would love that. That would be great. So the community is speaking. And of course, it is our priority to respond to what everybody is saying. And for everybody online to know, we still have 120 people online. This is your community. You get to define what we're going to learn and what we're going to focus on. And so, yes, we will do a session on that. You know, one of the most interesting things about helping a virtual community thrive is the community itself has to define its purpose and what will be of greatest value. And you're speaking loud and clear, and we are in service of that. So we will do that. As a time check, it is 9:15. An hour and 15 minutes has flown by, and we still have full participation with the odd person who had to leave, which is incredible, incredible, incredible. Robert, I want to turn to you and ask you to choose out of the next sections the critical pieces at this stage that we wanted to talk about: the relationships, how we build collaborative relationships, and how to lead from the edge, which is a huge quality improvement opportunity, especially for a virtual community coming together. How do we continue to build on our strengths as primary care and create positive contribution to Ontario's health system? And what learnings can we take from you? And Robert, with your permission, I am going to save 5 minutes at the end for us to do some closing pieces. But if you could take the critical pieces from this next section, and I know you'll be missing some, but we'll be able to come back to it. I'll turn it to you.
Absolutely. Thank you so much. So I think it's reasonable for people to observe that it's really common. It's not just Ontario. I've had the privilege of working with colleagues from primary care all over the world. It is really common for us in primary care to feel that we are always left out, or even we're always under the foot of other people in the health system and the government. Whatever the flavour of government, politically, whatever the type of system, I think worldwide, we have a mountain of evidence that shows the benefit of primary care for patients and populations, but we have not been treated well at all. I'd like to share a variety of different things that I think, on reflection, have been really key for us in our country over the last 5 years in getting a shift, and it has been a shift. So I'll share a story first. When I first started work in NHS England, the national body, we're sort of it's called arm's length body, but we're sort of like we're the arm of government. We're effectively the ministry. We set policy and we make payment decisions and the contracts and things. I was asked to come work specifically to look at what the future of primary care could be, to describe a vision for the future, to take stock of how primary care was doing right now, and to come up with some national priorities for action if we wanted to make the most of the potential of primary care. And after 3 months, I went back with my conclusions thus far, which said primary care is drowning. People are leaving the profession in record numbers. We're not coping with workload. That's unsafe. It's terrible. Secondly, people are innovating in really interesting ways. They're doing different things, demedicalizing and working in partnership for patients with multiple long-term morbidities. And thirdly, these are kind of working out in some really interesting new innovations, which we could spread if we had more money, more doctors, some changes in policy, and some improvement support and some leadership development. And I took this to the chief executive and I was laughed at. And I think he genuinely thought I was the warm-up for the staff Christmas party. That really was the response. It was clearly ridiculous to suggest that primary care should get more money. It was clearly ridiculous to suggest that we would prioritise work in primary care. And I did some work to understand why. And it was really clear that we had a real lack of trust bi-directionally. It was both trust from policymakers towards us. They saw us as too independent. They saw us as too business-minded, likely to spend the money on a nice holiday or a nice car rather than improved care for our patients. And they didn't actually trust that if we were given the opportunity to work in new ways in primary care, that we would actually rise to that challenge and be part of new integrated care. And then from the perspective of primary care, we saw policymakers, time and again, people would say they're only interested in the money. They talk about integrated care because they think it's going to save money. They're only interested in putting more money into primary care. And so the lack of trust, the lack of a clear rationale or a clear narrative and purpose, and the lack of evidence that given the chance, primary care could innovate and could be part of primary care, were, I think, the three big barriers to us making a reality of it. So one of the things that we did was to start building closer partnerships between policymakers, funders, and people in primary care. I started hosting lots and lots of roundtable meetings where we had leaders from the profession who were speaking on behalf of the perspective of primary care, and policymakers and politicians of all different colours, as well as the government, and as well as senior decision makers, all around the table talking again and again about this. And you start to build the trust, because one of the things you discover is actually, by and large, people are working for the same ends. They're responsible for different things, and that's why politicians talked more about money than we did. But actually, when you talked about the potential of primary care to serve patients better, the potential of primary care to keep more people well and out of hospital, everyone says, yeah, well, wow, if that's what matters to primary care physicians, then okay, let's talk some more. You have to do it over time. You have to get people who are prepared to act as leaders and act courageously, to be collaborative, to see each other's perspective. And that's not easy. It does take courage. You can't just go as a negotiator, we found. either side acting as a negotiator makes it very hard to have a sensible conversation together. But that was one key strand for us. The second one was actually to create a movement among colleagues. So we set up lots of communities of practice at local level, at regional level, at national level, for people from primary care to talk about what good would look like and what better would look like. And so we got a groundswell of not just the usual suspects, you know, the usual 50 or 60 people I could name who were my friends, who all thought like me and were cheering me on in my national role, but actually to get to the hundreds and the thousands of people who are saying, primary care is great, we're struggling, we could be better, we could contribute more. I wonder how. Has anyone got any examples? And then that was the third thing we did, was to seize those examples, to really spotlight them, to help to spread them. So to connect, yeah, if you've got that, can we help you tell that in a different city? Explain to people, how have you done that? How have you made that collaboration with the community nurses a reality? Let's learn about the real practical details of making that happen. So that over the course of, and it has taken us 5 years, we've just published a new future vision for the whole of the NHS with primary care at the heart, a new 5-year contract which commits us to increase funding year on year on year for primary care, as long as it's more joined up. It took us till this point to be able to do that. It took us 5 years of the relationships, of the narrative about why that connects a community, get a groundswell of movement behind people saying, yeah, we can do this, we should do this, it'd be better for our patients, I'd be less frustrated each day as a physician. And then thirdly, to be realizing, building on and rapidly amplifying the practical examples of how you actually make that happen. So I think I would say those are the key things that we have done to make a reality of it. And then, Jodine, you asked me about how one does it as a leader. And I think that's a great question. I would like just very quickly, so people can see it and photograph it, I've got a list here of, this is what I think we have learned that's made it better for us in the NHS when talking about making big policy work. I'm sorry for the slight clunkiness in particular. There we go, animation not working. Those are the things I think we've done. If you were to step back and describe, you know, what have we learned? How would we do it differently next time when setting big policy? It's these things. So that's kind of a big one. And then going down to the individual, we've made a big thing about saying that this kind of revolution or evolution, big change, can't happen just top down. It can't just be policymakers. It can't be well-known national leaders. It can't be only the funders. It can't actually just be the innovators anymore. If this is to be everybody, then we need, well, we think in our country, we need tens of thousands of nurses and therapists and doctors and managers and patients to be thinking of themselves as leaders of making primary care better and joining people up. We have found repeatedly that people are hesitant to do that because of their prior experience of the problem of power, and not having power in primary care makes you feel embittered and often sound embittered and act embittered around a table. We found, we're beginning to find, a new way of leading that doesn't depend on you being the person with power. It actually depends on a relational approach to influencing other people. There are lots of different ways of talking about it. I'll reference some of them and then show you a quote from a colleague of mine.
Actually, Robert, I'm going to ask you to
I'm going to show you that.
final comment.
Yeah, absolutely. For us, the key to all of this has been building on the values that we've all been talking about so far today, to actually lead with why. not to start with what needs to be different or what needs to be better or what the problem is right now, but to lead with why, and to talk about why it matters to me to release the potential of primary care, why it matters to me to see patients get a more joined up kind of experience from care, why I think that would be better for patients and better for payers and better for the community, why I would be less frustrated day in and day out as a primary care physician. And the nice thing about that is anyone can do that. Every one of us on this call can talk about why you're passionate about this. Hey, I joined a webinar and it was quite interesting. And we talked together about the future of Ontario health teams. And this is why I think there's something attractive about this. It's a really interesting way of connecting. It's a very different way of being a leader. It doesn't mean you have to wait till you've got the power. A colleague of mine, Sarah Jane Marsh, who is a chief executive of a hospital, someone asked her recently, how do you get so many people doing things that you tell them? And she said this, it's about the narrative. Tell a story that connects with why people are here. You find the common ground and you start getting movement. I hope that's an encouragement to us. I hope it unpacks some questions for you about your own leadership.
Robert, thank you so much. And could you please turn the controls over to Yinka for the PowerPoint? You know what makes me incredibly proud listening to your experience and your lessons learned for all of us. And then I'll be turning to everybody, and we still have over 100 people online, so thank you. We are committed to finishing on time, but we want to focus on a couple final things about the community. One is, this was meant for all of us. It is non-hierarchical. This is meant to inspire, connect us all up, and help all of us have a discussion and build a community about positive change in Ontario. And the kind of conversations that were taking place today really enabled that. I want to thank everybody online for how positive you were about what's possible, and also what would make you proud in 3 years. And there is no way we could achieve what would make you proud in 3 years if we weren't building on the strengths that already exist in primary care in Ontario and the leadership within primary care. And when I talk about leadership, I do not mean those informal leadership roles. Of course, that includes, it means all of us to lead from wherever we're at in every community we are at to, as in the words of everybody online, join us up, connect us up, use virtual means, look at electronic medical records, look at ways to positively contribute and have primary care at the center and an integral piece and part of integration. One of the pieces that has come up in the chat is you'd like to invite others to join. Some people talked about bringing their entire teams, administrators and others. We want this community to grow, and we would love for you to invite others. Can you just share on the chat who else you would like to join this community? We will send out the link to sign up. But we really do welcome anyone who sees themselves as part of the primary care community and wants to be joined up. Some of you may be asking yourself, all the FIT executives, okay, some of you may be asking yourself, why just focus on primary care if we're talking about a whole integrated care community? And the idea is build a sense of community together and link us up to the rest of the community. And if the change can't, all the chiefs of staff and CEOs of hospitals, okay. If the Change Foundation can help convene a space that connects us all up in a neutral way to build the community, and the community itself comes on board, we are in service of real positive change in Ontario, and it's our pleasure to do that. So a couple things, keep it coming in. Who else should be invited? Know that we will send in the link to sign up that you can forward to others. We are recording this session, so you will have it and you can share with those folks, and we will also share it out. I want to do a quick exercise called a snowball. Is everybody ready? All 100 plus of you. Send one word that describes your experience with the virtual community today. Just one word. It's a mini evaluation. One word with your experience of this hour and a half with us. Inspired, 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 inspired. Yay! You know, that's such music, because you can only start from a place where you feel that you believe in something worth it, inclusive, hopeful, motivating, collaborative, uplifting. Wow, I hope we all feel so proud, hopeful. if this community and the Change Foundation platform serves as a place of inspiration and to bring everybody together so we can move forward in partnership, it would make us so proud. I'd like to turn to Rob and Sarah to thank Robert and for final remarks. And we all look forward to seeing you again. We'll be doing this monthly. Rob, Sarah.
So really, I just want to say thank you. I'm coming away feeling hugely inspired by Robert's conversation with us today and by the depth of engagement of folks in the chat space, and really feeling quite lifted up by the relationship. I think in many ways people have felt an energy ebb in the province of Ontario, and I'm hoping that this is helping to fill the tank again and helping people to step in to that space of leading in their practice and engaging with colleagues. So thank you all so much for being part of the day today. Rob.
Yeah, just very briefly, on behalf of the physicians in Ontario and other primary care providers, Robert, we really want to thank you for your insights. The experience in the NHS is very, very helpful for us. And then to all the people who've been involved in putting this together, especially the Change Foundation, Jodine, done a great job to excite and inspire the group. And I think this is something that will definitely keep going. So thank you very much.
Thank you for the honor and the privilege. I'm joined by Yinka and Kareem, who made this all happen, and thank you, everyone. And, you know, the final remark from Ruth, really ideal timing. And, you know, big thanks to everybody, and we look forward to seeing you again. Bye, all. Rob and Sarah, thank you, thank you. And to the Ontario College and AFTO for asking all of us to come together to do this. And Robert, we'll be seeing more of you, thankfully. The community
Thank you
is
so
spoken.
much. It's such a privilege to have joined you.
Us too. There's so many thank yous online. I know we could go on forever, but we'll keep the line open for a sec so everyone can send their final chats in. You're welcome, you're welcome, you're welcome. Thank you for mentioning the facilitation. I want to do right by all of you, so thank you.